So this afternoon we have the pleasure of having Dr. Napolitano with us. And Dr. Napolitano works as a consultant medical oncologist in the sarcoma unit here at the Royal Marsden. He graduated from the university campus Biomedico in Rome in Italy and obtained his PhD in molecular biosciences and bioengineering in 2015 at the University of Hawaii. Such a lovely place. Following this, Andrea completed his residency in medical oncology in 2021 back at the University campus Biomedico in Rome. He is heavily involved in translational and clinical research in soft tissue sarcoma, GIST, and desmoid fibromatosis. Sorry. He's been involved in several phase 2 and 3 clinical trials and has co-authored more than 50 peer-reviewed articles, publishing papers with some of the speakers here from today. Andrea's personal interests include writing, scientific and medical communication, and in particular the role of personal narratives in social and medical interactions. If anyone's interested in asking about knowing more about that during the break, then feel free to ask. And new biotechnologies and physics. So I'm keen to find out more about trials and treatments. So without further ado, please welcome Andrea.
Thank you very much for the kind introduction, and I hope that you really had a very good lunch. So we're going to start with a game, because I thought that was the nicest way to ease into the presentation. And some of these definitions are pretty easy, so I'm not going to make it too difficult, but if you want to join and participate into the game, really happy. So we're going to start with 5 down, the specific sarcoma subtype that we are discussing today. That's easy. Well done. Then we go to the fact that actually, as you've heard from all the speakers before me, leiomyosarcoma actually is not just one type of disease, but there is significant heterogeneity in terms of location, clinical behavior, and molecular subtypes. And I think that this is really important because, as you will see, the trend is to try not to treat all leiomyosarcoma as one disease, but also in the clinical trials, we're trying to really personalize the treatment and identifying different subtypes that could benefit from specific treatments. Next, cancer treatment based on cytotoxic drugs. These are drugs that kill cancer cells directly.
Chemotherapy.
Well done. And again, there are different mechanisms of action in chemotherapy, so we need to really be careful when we just say chemotherapy, because that's a buzzword for many different drugs that work in many different ways. Some of the most common chemotherapies work damaging directly the DNA, but there are also chemotherapies that can change the transcription of the DNA, so the RNA, which is what Paul was discussing about. We have other chemotherapies that can damage the cellular architecture, like microtubule inhibitors. So the damage is not to the DNA level, which is where the information is contained, but is actually in the structure of the cell itself. And then we have, as we've seen with Emine's presentation, there are also chemotherapies that can actually change the tumor microenvironment and alter the immune infiltration. This is objective of an anti-cancer treatment altering the circulating levels of estrogen, because that's something that we haven't talked about today. But in leiomyosarcoma, there are some patients that actually can benefit from hormonal treatment. This is something a bit controversial up until a few years ago, because the idea of low-grade leiomyosarcoma was not entirely accepted in the sarcoma community. Most leiomyosarcoma are considered by default high-grade disease, but we know that there are so-called STUMP, so soft tissue lesions of unknown malignancy, especially in the uterus, that do express estrogen and progesterone, and sometimes they recur and they start to behave more like leiomyosarcoma. So this new, if we want to say new entity, is being increasingly recognized, and we have to consider hormonal treatment as well for these patients. So we may consider, not a lot of research in this field, but I think that that's a different type of disease which should be considered, again, as a subgroup of patients where we have to offer more targeted treatment. Novel way to fight cancer, stimulating the immune system, again, an easy one. As we've seen, it's not a standard treatment. Primary resistance is very, very common across sarcomas in general and leiomyosarcoma specifically. But we're trying to improve our ways to understand why this is the case and try to identify ways to overcome this primary resistance. Of an anti-cancer treatment directed to a specific molecular alteration, there's another buzzword, targeted therapies, but targets are often subgroup specifics. Some targets are better than others, and then we have to define what better really means. Is it how frequent they're expressed, how strongly they're expressed, if they have any specific relevance in the cancer growth and metastatic process, or if they're just expressed. So we have different type of targets. And again, the validation of a therapeutic target is a complex process. Now, to add systematic investigation of a phenomenon, which is what Paul does. As he mentioned, we have preclinical in the lab, translational, taking pieces of tissue from the patients and studying them in the lab. And then we have clinical research, which is what we're going to discuss now. But this is a circle. It doesn't really go in one direction. Whatever we find in the lab informs what we're going to do next, but whatever we can find in the clinic, as Paul was mentioning, in every trial we usually have some long-term responders, and analyzing retrospectively the characteristics of these long-term responders can inform our preclinical research and our translational research. So we have to imagine the research process as a continuum. And finally, what we're going to discuss now, trials. Formal examination of the safety and efficacy of a new intervention in general. But even in trials, we have different phases. Phase 1 is mostly trials where we're actually testing the dose of the drug, we're identifying what is the safe dose. In the phase 2, we are optimizing the dose and we're looking for signals of efficacy, of activity of a specific drug. Phase 3, which are usually the big randomized trials, are the ones where we're comparing the efficacy of a new compound versus a standard of care, if there is one, otherwise versus a placebo. This is commonly done. And then there is phase 4, which is the post-market data collection, which is not really a trial, but it's trying to gather data regarding whether what we see in the real life in patients outside of clinical trial matches what we actually showed in the clinical trial, because the clinical trials, as you well know, they select specific populations that meet inclusion and exclusion criteria, but these are not necessarily the case. This is not necessarily the case for patients treated in real life. So with all that, I hope that some of the words that I'm going to be using are a little bit more clear and in context, because there is a lot of complexity, and the complexity is further augmented by the fact that now we're combining things. So we're combining immunotherapy and targeted treatments, we're combining immunotherapy with chemotherapy, and so forth. So all these elements, which are complex on their own, are exponentially made more complex by the fact that we like to combine things. Chemotherapy and targeted agents. So we're going to start with combination chemotherapy. And I'm going to give you a few examples for each of these classes. So we're not going to go into the details of all the clinical trials available, because that's really impossible. But it's just to try to give you sort of an understanding of what the direction of research is and what we might expect in the near future. So why combination chemotherapy? Because we're targeting cells which are in different phases of the cell cycle, and this can actually increase the percentage of patients that are responding and the depth of the response. We're targeting same cells in different ways, and that can decrease the chances of developing resistance. So the objective of combining treatment is to try to maximize the number of patients that are responding and the duration of the response in these patients. So one of the main trials that we need to discuss at this stage is the Sunrise Leiomyosarcoma trial, which is a study of unisbolin in combination with dacarbazine in patients with advanced leiomyosarcoma. And of course, thanks to PTC. No conflict of interest. I'm going to just be discussing these as all the other ones. It's a randomized trial, which means that some patients will be are being allocated to the combination of unisbolin and dacarbazine, whereas other patients are allocated to dacarbazine plus placebo. And it's a blinded trial. We don't know what we're giving to the patient doesn't know, and this is how trials should be conducted. As Paul mentioned, just to maintain ethical standards that avoid that the physician's interpretation of the results can actually affect the readout. It's a phase 2-3 trial, and patients must have received at least one prior systemic line of therapy for leiomyosarcoma. Now, we do have some preliminary results which were presented at the ASCO meeting in 2022, and these are the results from the phase 1b part, which is the earliest stage of the trial when the primary objective was to identify the correct dose to then test it in a larger population. But even though the goal is to try the dose, you can still see if the drug is effective. And at the dose that was selected, which is unisbolin 300 milligram pacing week plus dacarbazine, the overall response rate, so the percentage of patients in which the tumor shrunk by 30% or more, is 20%. Appreciate that this seems like a relatively low number, but the overall response rate for single agent doxorubicin in the first line is even lower. So we have to consider the fact that these are patients that have already been treated, and that 20% in our field right now is a good response rate. And the disease control rate, which is the number of patients that did not progress on the drug as their best response, is about 60%. Now, what is unisbolin? What is dacarbazine? Unisbolin belongs to the family of what we call microtubule inhibitors. As I briefly mentioned before, there are some drugs which do not actually damage the DNA, but they are blocking these microtubules which form the architecture of the cell, which is particularly important when the cells are dividing, because for a cell to divide, we need to have a significant production of these microtubules, because it's like one cell building the skeleton for the future cell before the division happens. This is the process called mitosis, and there is a lot of rearrangement of these microtubules as they interact with the DNA and as they split the DNA into the two separate cells. And microtubule inhibitors are not a new class of drugs. We have vinca alkaloids and taxanes, which are also in the same family. Unisbolin is the next generation microtubule inhibitors. So there is a rationale for using it. And the reason why we combine it is because whilst we're damaging the supporting structures of the DNA and the cells, we're also using dacarbazine, which instead is an agent that directly targets the DNA and causes DNA damage. So with this combination, we're actually targeting the cancer cells with two different mechanisms at the same time, with the hope to achieve more profound and more lasting responses compared to either agent alone. And of course, there is a lot of hope, but the reason why we run clinical trials is because we want to have proof. Another example is a study of lurbinectedin in combination with doxorubicin versus doxorubicin in first-line treatment but with metastatic leiomyosarcoma. Again, randomized trial, patients are randomly allocated to receiving the combination of the two drugs or just doxorubicin. It's a phase 2-3 trials, and this is in first line. So these are patients that have not received any prior systemic treatment, and it's currently enrolling in the US and will hopefully open soon in the UK as well. Similarly to the unisbolin trial, we already have some preliminary data from the phase 1b, so from the efficacy, from the dose finding results, and in this case, the authors reported an overall response rate of 60%, which again is impressive, but that was based on 10 patients, so it's not as impressive. So we need to see if these results are confirmed. And then there is a bit of discussion about this trial that I'm happy to briefly introduce, and we can take it further if needs be. Now, what is lurbinectedin? Lurbinectedin is a chemotherapy derived from an early compound called trabectedin, which we will mention soon. And it acts damaging the DNA, affecting the RNA transcription, so both DNA and RNA, but as the cognate drug trabectedin, it also attacks the macrophages in the tumor, and that is why it's considered to have also immunomodulatory properties, which other chemotherapy drugs don't have. Doxorubicin, I'm not going to say anything. I think that you know exactly what it is, what it does, and how it's being used. Now, this trial is built on the results of a combination of trabectedin and doxorubicin. So the trial that is going to be open is lurbinectedin plus doxorubicin, but we already have the data of trabectedin plus doxorubicin in the first line in a French trial. And as you can see, the red curve is doxorubicin plus trabectedin. Patients had significantly longer time until developing progression compared to the doxorubicin alone. There is a caveat, which is that in most countries, trabectedin is usually given as a second or third line therapy, so there is a sequence, whereas in France, especially when this trial was conducted, they didn't really have, not all the patients had access to trabectedin. About 40% of them received trabectedin as a subsequent therapy. So whilst we know that the combination is better than the single agent doxorubicin, the real question that we currently don't know is how does the combination compare to the sequence of the two drugs? And that is a question that has not been addressed in this trial and is not going to be addressed in the lurbinectedin trial, because it will be just a comparison of the combination versus doxorubicin in the first line. And of course, everybody in the scientific community expects lurbinectedin to perform very similar to what we're seeing here from the combination of doxorubicin and trabectedin, because trabectedin and lurbinectedin are very, very similar also in terms of structure. One is a derivative of the other. So this is an eagerly anticipated trial. It will definitely show that the combination, it's highly likely they will show that the combination of the two drugs in leiomyosarcoma first line is going to be superior in terms of progression-free survival compared to single-agent doxorubicin. In some countries, it may become the first line for leiomyosarcoma patients. But the question will remain, and it's up to us to address it, whether this combination actually improves the overall survival, or if receiving single-agent trabectedin after single-agent doxorubicin actually leads to the same long-term outcomes. Because even though there is better efficacy, I'm not going to show you the data about toxicity, because trust me, it is more toxic as well. So we have to, especially in a setting, context of a metastatic disease, it's true that we're aiming to longer survival, but we also have to balance that with toxicity. So it will be interesting to see in a large international phase 3 trial how the combo is going to perform. Targeted therapy, so we are exploiting cancer-specific molecular alterations and inhibition of pathways. There are two main ways. One is inhibition of pathways are directly stimulating the tumor growth. We often do this with compounds which are called tyrosine kinase inhibitors, because they block specific receptors which are called receptor tyrosine kinases. Or sometimes we actually stop pathways which are necessary for the cancer cell to grow if they harbor other cancer mutations. It's a concept that we call synthetic lethality. Paul mentioned it before. For example, the use of PARP inhibitor in cells or in patients that are carrying mutations in the BRCA2 or related pathway. The APROMISE trial is a trial that we for which we recently finished enrollment in the leiomyosarcoma cohort. We had it also at the Marsden. We're waiting for the analysis. This is a phase 3 trial of allotinib, also known as catequentinib, in advanced alveolar soft sarcoma, leiomyosarcoma, and synovial sarcoma. The only cohort that is currently recruiting is the alveolar soft part sarcoma. Leiomyosarcoma and synovial sarcoma have completed recruitment, so we're just waiting to see the results. Again, randomized trial, the control is dacarbazine for the leiomyosarcoma cohort. Phase 3 must have received at least one prior systemic therapy. The use of allotrinib, which is one of these tyrosine kinase inhibitor, is not entirely new. As Emine also mentioned before, well, first how the drug works. These are receptor tyrosine kinases, there are a number of them, and allotrinib specifically blocks some vascular, some kinases which are involved in the vascular remodeling, which are called VEGFR, vascular endothelial growth factor receptors 1, 2, 3, and other related molecules. So these are small molecules which block these active receptors on the cell surface. But again, as I was mentioning, this is not an entirely novel approach in sarcoma, nor in leiomyosarcoma specifically, because we have the data of the Palette study, which was testing pazopanib, which is also a multi-tyrosine kinase inhibitor. It's difficult to compare one with another because the inhibitory activity on different receptors is slightly different, but as a class, they work in very similar ways. And the trial was overall positive for progression-free survival, but if we look at the subgroup of patients that benefited more from pazopanib compared to the placebo, as you can see in the left panel, leiomyosarcoma was one of the two histologies together with synovial sarcoma, where the benefit was more in favor of pazopanib compared to the other sarcoma subtypes. So if you see there is the black box, which is basically how the benefit is for one treatment or the other, for leiomyosarcoma and synovial sarcoma, is more to the left compared for the other sarcoma subtypes, where still it favors pazopanib, but to a lower extent. Another possibility of treatment that we mentioned is the targeted therapy with PARP inhibitor, and olaparib belongs to this class. There are a number of trials testing PARP inhibitor for leiomyosarcoma, in particular uterine leiomyosarcoma, because as Paul mentioned, the frequency of alterations in the pathway of BRCA2 and the homologous recombination pathway in general are more common in uterine leiomyosarcoma. These are just two examples. And one has finished recruitment, and the other one is recruiting at the moment. And in both trials, as you can see, the olaparib is given in combination with a chemotherapy, which is called temozolomide. Temozolomide is very similar to the dacarbazine that we mentioned before. It's an alkylating agent, so it causes DNA damage. And why has it a very strong rationale for being used together with olaparib? Because the pathway that PARP is involved with, which is the homologous recombination pathway and DNA damage repair pathway. So basically, if you block PARP and your cells are already carrying defects in the DNA damage repair, the overall activity of the DNA damage repair pathways is significantly reduced. So if you're adding another drug which is causing DNA damage, that DNA damage cannot be easily repaired. Whereas normal cells, the activity of repair is somehow preserved. So the combination has a very strong rationale when there is a defect in the DNA damage repair pathway called homologous recombination pathway. These damages, again, PARP inhibitors are particularly effective in cancer cells with this deficient homologous repair. There are already been published results from the phase 2 study of olaparib and temozolomide, which is the first study. Overall response rate of 26%. Again, these are patients that have been pre-treated. Median progression-free survival was in about 7 months, but in patients that had evidence of homologous recombination deficiency, this median progression-free survival was actually 11 months, so almost doubled. And this is again to stress that we're going towards the understanding a little bit better the biology, but also translating our understanding of the biology into selecting the right patient for the right treatment. In this case, an assay which is called RAD51 assay was done to identify patients that had the homologous recombination defect. It's an immunohistochemistry. It can be easily done in many laboratories. So this will need to be further validated by other studies, but the direction is that for patients with leiomyosarcoma and evidence of homologous recombination deficiency, the use of PARP inhibitor, very likely in combination with temozolomide or similar drugs, is going to be part of a clinical armamentarium. There are a bunch of other studies combining other chemotherapies with PARP inhibitor or PARP inhibitors with immunotherapy as well, because of course if you increase the DNA damage, you're also increasing the number of antigens of that the cells of neoantigens that are present in the tumor that can further stimulate the activity of the immune system to recognize the cancer. But I think that I just want to focus on this one because I think this is the first step. Once we can show that indeed we're able to provide better results in this subpopulation, then the further step would be to see whether this treatment is actually synergizing with immunotherapy. But I think that it's going to take a few years before we are ready to apply that in clinic. This is another targeted therapy trial of a completely different class of drugs, which is the reason why I put it here. We're talking about ADPEG-20 or placebo plus gemcitabine and docetaxel in previously treated subjects with leiomyosarcoma. Is enrolling in the US, and again, randomized trial, placebo-controlled trial, phase 3 trial. So I want to take just a minute to highlight the fact that yes, we're talking about a rare disease, but there are lots of randomized trials, a lot of controlled trials. These are all trials which are being conducted following the most rigorous ways that we know to conduct a clinical trial. So I think there's a community of patients and doctors. We're actually moving toward being able to conduct relatively large clinical trials and creating high-level evidence which can guide our treatments. We're moving a little bit away from case reports, small series. I'm doing this in my institution, you're doing that in your institution. So I think this is really something that makes me really hopeful because with time, at least we know that we will be building strong evidence in one direction or another, but it will be strong evidence, and that's what we need. So going back to the specific trial, why ADPEG is fun? For this reason, because it has a completely different mechanism of action compared to what we discussed so far. We know that cancer cells have a different metabolism compared to normal cells. As you can see, Ed already left because he knew that I was going to show one of these slides. So the metabolism of cancer cells can be quite different, and in particular, we know that many cancer cells do not have a way to metabolize arginine and to create, they have to create arginine from scratch, basically. And when we block the enzyme that is responsible for the metabolism of arginine, this can actually lead to imbalances in all other metabolic pathways, including reduced protein synthesis, increase of apoptosis and autophagy, which are forms of cell death, and then changes in gene expression. So in particular, in tumors whose growth is really dependent on arginine, blocking these enzymes seems to be very, very promising. Now, the enzyme itself, the ADI, which is the arginine deaminase inhibitor, so the inhibitor of the enzyme, is not pharmacologically very efficient, and that's why, to make it a little bit better, is conjugated to this pegylated molecule. That's why it's so bulky. So the green molecule at the center is actually the inhibitor, but if you give it like that, it doesn't work. It's eliminated by the body, and it has a very short half-life and is not soluble enough. But if you coat it with this pegylated structure, it actually becomes pharmacologically useful. So this is also an example of trying to, how do we translate from the lab to the clinic? There are tools, we're getting smarter at that. We're trying to identify also what is the best way to deliver a new drug, which we were not able to do until recently. Gemcitabine, you already know what it is, a nucleoside, so it blocks the RNA, it can block the DNA and cause changes in the transcription, DNA damage. And docetaxel is again one of these microtubules inhibitors, and the combination of the three is being tested. Now we go to another targeted, but this time is a targeted chemotherapy. It's not a combination of two drugs, but it's taking the best of the two worlds and trying to put it together. The reason why I decided to discuss about these molecules is because in the most recent meetings that we've been in Madrid, the ESMO oncology meeting, these molecules, this class of molecules called antibody drug conjugates, has made a lot of news because it's showing to be really effective class of drugs. So how do they work? They work with an antibody specific for a protein, but the goal is just to use the protein as an anchor to selectively bring the chemotherapy to the cancer cells. This has two advantages. It will increase the concentration of the chemotherapy in the cancer, and it will decrease the concentration of the chemotherapy in all the other normal tissues. So that gives better efficacy and lower toxicity. This strategy has proven quite effective in lung cancer, breast cancer, and urothelial cancer most recently. It's not there yet for sarcoma. First of all, because we didn't have, and possibly we don't really have, good anchors to which target our antibody. A promising one is a molecule which is called AXL. It's also a receptor tyrosine kinase, but in this case, we're not really interested with this molecule in inhibiting and blocking the kinase. We're just using that kinase as the anchor to increase the concentration of chemotherapy that we can safely deliver to sarcoma patients. And there are two trials testing this approach, slightly different drugs made by slightly different companies, but overall this looks like a very promising approach. The identification of molecules which are more specific in the sarcoma, in the leiomyosarcoma compared to normal tissue is key, and that's why also the research that Paul is doing in proteomics is really, really important. Because if we can identify targets which are specific for the sarcoma, then we can create antibodies to deliver the drug only to the cells which express these molecules. Immunotherapy, of course, we couldn't skip it. Stimulating the immune system to recognize and fight the cancer. Very successful strategy in other tumor types. In sarcomas, the results have been so far disappointing. I mean, I showed a couple of studies which were not really great, but we have to start from somewhere to gain more knowledge and to change the way we treat the tumor. The list is too long. This slide has been shown, or a similar slide has been shown by many people. There are lots of targets that we can use. Multiple resistant mechanisms, single agent activity, very limited in soft tissue sarcoma. I'm not going to cover those studies. The only thing that I want to stress is that, as Emine mentioned earlier today, most of these targets are actually expressed by T cells, which are a subset of lymphocyte, and another type of cells which we call dendritic cells, which are important in activating the T cells against the cancer. And also to comment on one of the questions from before, T cells are considered the most important effector cells. These are the cells that kill the cancer. So it's normal that most of the investment was done initially targeting the T cells, which again are the ones directly doing the job. And in some tumor type, like melanoma, that's enough. But in sarcoma, we learned that macrophages and other cells are more important, they're more prevalent in the tumor tissue. So when we think about combination with checkpoint inhibitors, so molecules that the current immunotherapy, we can combine it with everything and anything. Again, in sarcomas, last time I checked, there were about 100 even more clinical trials testing this combination in soft tissue sarcomas in general. Many of these trials enrolling patients with leiomyosarcoma. Personally, I think that these research are very much driven by opportunity and interest of pharmaceutical companies rather than by the biology of the disease. So I think that before jumping into combining new things with new things or new things with old things, we need really to understand a little bit better the biology. This is a study that we did at the Marsden, combining pembrolizumab with gemcitabine in leiomyosarcoma patients. It was an academic study, no randomized phase 1-2, so dose finding and just to capture signals of activity. We enrolled first 13 patients in the phase 1 and the expansion cohort with another 15 patients that also completed enrollment. We're waiting for the full results to be ready. Paul is doing some translation analysis to try to identify the immune infiltrate in these tumor samples and how it associates with the response to the treatment. And pembrolizumab is an inhibitor of PD-1, so one of those famous early checkpoint and one of the first drugs to be developed in the field, highly effective in other tumor types. In our hands, the combination has proved safe. In terms of efficacy, we can't really comment because, again, this was a phase 1-2 study, so it was more to identify the dose and to check for efficacy as a single agent, but we didn't really, as a combination, but we didn't really compare it to gemcitabine alone, so we can't comment on that. This is a molecule that makes me really, really excited because, as Emine mentioned, and as we say, the macrophages are the next frontier. Not many drugs have been developed to target the macrophages. We mentioned that trabectedin and lurbinectedin may have some activity against macrophages, but it's a sort of a positive side effect. It's not the reason why they were designed that way. This is a new molecule which instead is an antibody fused with a receptor to target SIRP-alpha, which is a protein expressed by the bad macrophages. And the idea is that this could be one of the first in its class molecules to actually target these macrophages, to eliminate these macrophages, or to reactivate them from being bad macrophages supporting the tumor to anti-cancer macrophages. And it's being studied in patients with leiomyosarcoma specifically because, as we said, leiomyosarcoma is characterized by a very high prevalence of macrophage infiltrate and is given alone or in combination with doxorubicin. Enrollment has been closed, but we're waiting for the analysis of these results. At the ESMO conference, there was a very nice presentation from Professor Bree Wilkie. This is second generation checkpoint inhibitor, so the targets are the same, but the molecules are slightly better. In particular, botensilimab and balstilimab. The botensilimab is an anti-CTLA-4, but a new version of an anti-CTLA-4 with improved characteristics. And again, these were patients that were pre-treated with chemotherapy. If you look at the graph on your right, you can see that a lot of angiosarcoma patient AS had the tumor response, but in purple, leiomyosarcoma. And there are 1, 2, 3, 4 patients out of, I think, 10 or so, which is not a low number, where we are starting to see activity of immune checkpoint inhibitors, which is something that we didn't see with the first generation. So even the T cells, probably, if they're stimulated in the right way with stronger immune checkpoint inhibitors, can have activity in leiomyosarcoma, which is something that we were not expecting. And this is, of course, very, very exciting because it opens a field of saying, okay, why are these molecules working and the first generation not working? What can we understand from these differences? How can we improve understanding these differences? So what's new? Several leiomyosarcoma-specific trials, plus general sarcoma trials. And again, these are often phase 2 and 3 randomized trials conducted in the best possible way. Preclinical and translational research identifying new targets. We're moving towards combination to overcome resistance to single-agent therapies, but what about toxicities? And finally, moving towards biomarker-driven therapy to maximize the benefit in enriched subpopulations. And finally, of course, there is always need for more international collaborative studies with patient support in defining relevant endpoints. Thank you very much. Happy to take questions.
Thank you very much. This works, doesn't it? Does anyone have any questions?
No. I took part in the Strauss 2 pre-surgery chemotherapy. So I had doxorubicin and dacarbazine times 3. Then, unfortunately, I got a recurrence after surgery 6 months later, and now I have metastases. But I was aware of the Sunshine trial, but I couldn't have it because I'd already had the dacarbazine. But I'm now on trabectedin, and looking at there's now the trabectedin and doxy trial. Because I've already had now 3 different kinds of chemos, does that mean that I'm never going to be eligible for the trials where they include one of those chemotherapies?
Most trials do exclude patients that have already had some of the treatments which are being tested, either in the control arms or in the combination. But that doesn't exclude you from trials that are not testing any of these drugs. For example, in the Sunrise, yes, because you had already dacarbazine, you couldn't go on the trial. But the AXL targeted trial, it doesn't matter what chemotherapies you had before. So it really depends on the individual trials. When you're comparing 2 drugs or a combination with a single agent, almost always previous exposure to one of the drugs is going to be an exclusion criteria, because we want to, of course, get clear data in a way. I know that's not a nice way to say it, but you want to understand and compare without confounding factors. And previous exposure to one of the 2 drugs will be a confounding factor. But if you're in earlier phase, like phase 1 or phase 2, we're not comparing against anything. We're just giving the drug and testing safety and efficacy. And in those trials, usually there is no mention of prior exposure to something as an exclusion criteria. So yes, not all trials will apply to all patients, but that's the reason why we want to have more trials, so that all patients might be eligible for at least one trial.
Okay, thank you.
Hey, you mentioned the doxorubicin and trabectedin study, and you talked about how it would have to be compared to dox plus trab in sequence. But wouldn't we also want to know dox plus trab, whether that's better than dox plus dacarbazine, since...
To be honest, at the most recent ESMO meeting, where some of the results about the combination were presented, there was a heated discussion right about that. The thing is that dacarbazine is based on retrospective data. We don't have a prospective trial showing that dacarbazine is better than doxorubicin. So we use it because in clinical practice, dacarbazine has been used, and because it has been used in clinical trials in the past. If we put together the evidence, we're relatively convinced that dacarbazine is better than doxorubicin. But there is not a single study showing head-to-head that dacarbazine is better than doxorubicin alone. So when the trial was designed, of course, the French group, they had to pick a comparator, and they went for the standard of care on paper, which is doxorubicin single agent. And that, of course, is also sort of a political choice, because if you're picking a single agent as your comparator, you're more likely to show that your combination is better than the doxorubicin alone. So that is created a fracture within the European sarcoma community on this particular topic, because we have the French group saying there is very high quality evidence of the fact that doxorubicin works, and the Italian, Spanish groups saying, yes, but you didn't show it against doxorubicin, which is exactly your question. I don't have an answer. No one has an answer. We will not have it because there will not be a study comparing with doxorubicin. But the real problem is that the doxorubicin lurbinectedin trial, which will open, also has doxorubicin alone as the competitor. So when that trial will prove positive, which is likely, there will be patients and doctors saying, okay, but you didn't compare it to doxorubicin. Is it more toxic or less toxic? Does it work better or less better than doxorubicin? And we don't know. Sorry.
You mentioned hormone therapy. Oh, you mentioned hormone therapy. In my conversations with various people here, it comes across as they don't know if their tumors were tested for hormone receptivity, and they don't know. They look at me kind of deer in the headlights that they didn't even know hormone therapy could be possibly an option. So one question, do you know, and maybe this was a question for earlier, if it's your pathologist will automatically test the tumor once it's received for hormone receptiveness? And two, how do you have, I'm wondering how to help these patients to advocate for themselves to receive that therapy if it's, I mean, you had mentioned it at first, but you also said that it comes across as a little bit controversial.
Yeah. I'm happy to provide a bit of context. So the expression of hormone receptors in leiomyosarcoma is often related to the grade of the disease, and also our attitude towards giving or not giving hormonal therapy is somehow related to the grade of the disease, because if you have a high grade disease, you're less likely to have expression of hormone receptors, and if you have a very aggressive disease, like a high grade disease, our understanding of the biology is that we will be more prone to offer chemotherapy because we have an aggressive disease which doesn't usually express hormone receptors. In leiomyosarcoma of lower grade, our pathologists tend to do the analysis of the hormone receptors, and if they don't, we often ask it. But these are patients that they tend to have slowly progressive disease with an indolent clinical behavior, and they are usually low-grade disease. So when you have a more indolent disease that does express hormone receptors, those are the patients with whom we discuss the option of hormone treatments. But there are two preconditions. One is that the disease is usually low-grade on the biopsy or on the tissue, and the second is that the clinical behavior is of being a more indolent leiomyosarcoma. We have several patients with metastatic lung disease without any treatment. They do not really progress radiologically for many, many months. So patients with a more indolent disease and hormone expression, we tend to offer it. But it's controversial. We don't have a randomized study showing that those are the patients that really benefit. That's why it's a treatment that I would not really advocate for the treatment outside of expert centers which know when and how to change and go back onto chemotherapy if needs be, because there is a chance that to start a hormonal treatment, you may miss a window of opportunity to start what your standard treatment would be, for example, doxorubicin. So it's a complex decision which is not supported by randomized phase 3 trials. We know that that subpopulation exists. At the Marsden or in other expert centers, we feel comfortable in treating those patients because we know how to look after them, we know how often to repeat the scans and when to change the strategy if we realize that it doesn't work for that individual patient. But as a general rule, it's not something that you can apply to all centers. So it's a complex topic, and I don't feel, I wouldn't advocate for the use of hormonal treatments in all leiomyosarcoma patients just because they express hormonal receptors, because sometimes they're high grade with hormonal receptors. I will not prescribe hormonal treatment in that case. The grade, for me, takes priority. If they're low grade with hormonal receptors and clinically less aggressive, then yes, but again, within reference centers, probably it's better.
Can I have a follow-up question?
Sure.
I'm here. But actually, this might have to be, we're about to go into a break.
Were you only talking about when there's disease, whether to treat with chemo or hormonal? But what about using hormonal treatment adjuvantly?
So the evidence is even lower in the adjuvant setting because we don't have target lesions to follow, which is something that was mentioned before. So whereas in the metastatic setting, we do have case series, we do have retrospective studies from the Marsden, from the center in Milan, or some prospective small studies, phase 2 studies, that show that the lesions actually, they were growing before and then they stop growing or they shrink. So it is difficult to select the population, but you still have a target. In the adjuvant setting, to show efficacy in the adjuvant setting, you really need to have either a big advantage or a small advantage, but a huge population. Because the event that you will be measuring, which is the recurrence, is an event that by default is not going to happen in all the patients. If you have a recurrence, 30% of recurrence rate, and you want to show a significant difference, then you want to show a difference from 30 to 20. From a statistical point of view, to design a study that shows a 10% difference, you need 300 patients.
Thank you very much. Just another question, which was, so for friends here, how do we know what, it's great that you've shown all the trials that are available at the moment, well, that you've highlighted. How do we know that that's what's best available for us? Is there somewhere that we can go to find all the latest trials? I know that you can look on Sarcoma UK's website, but is that all the trials in its entirety? And is there anything that we end up missing? And if we wanted to, so say in the UK, we wanted to join a European trial, is that not possible?
So,
yeah, that's it. Clinicaltrials.gov.
yeah, that's what I was going to say. It's not very user-friendly, but now they've made a new website, which is clinicaltrials.gov.
So that should be everything?
That has all the trials in all the cancers, and in all type of diseases, actually. And you can select by region, by state, and you can just type your disease, and you will have a list. Now, for a patient to navigate the trial, I think it can be quite difficult because, of course, every trial has this inclusion and exclusion criteria, and for an individual patient to know whether they fit, these inclusions and exclusion criteria is not easy. So, at least in the UK, but in many other countries, sarcoma patients are treated in sarcoma reference centers. And the sarcoma doctors, it's not many of us, they do know which trials are open where. So if you are interested in participating in a trial, which is something that not all patients are, the easiest thing to do is ask your oncologist and say, okay, do you know of any trial? If you don't, would you mind contacting somebody else that may know which trials are open because I'm willing to travel, if that's the case. That is probably the most direct way, and this is how we get most of our referrals from colleagues working in the UK and also from other countries, because the interest patient asks to the clinicians, I want to be part of a trial. Is there anything that can work for me? Navigating on clinicaltrials.gov, complicated. Patient association like Sarcoma UK, definitely more user-friendly and usually very much up to date. So that can be an easy intermediary in a way, even though I think that in the first instance it should be asking your oncologist.
Thank you very much.
From an international and European, we have our database in the support line, but Find Me Cure is another good website that we recommend on the support line. I don't like the title, but it's Find Me Cure, and it was set up by a woman whose sister had a gynae cancer. She just couldn't find any blood. You can put anything in there, will tell you all the trials open in the world.
Okay.
And it's a really efficient and easy to use tool.
Yeah.
So put that on your list as well if you're looking for trials.
Thank you very much. Okay, so we have to go into having a break now. Last question was magic bucket, maybe one sentence.
I'll give the money to Paul. I'll give the money to Paul.
Thank you very much.